Hi, can I say a big welcome to everybody. I'm Sam Everington. I'm the president of the Guild and a GP in East London. And the first thing I'd like to say is it's just lovely to see you all. It's like a family reunion post-COVID. And I'll never not think it's really special ever anymore after 2 years of hell. And I'm sure most people felt that's what it was like for those 2 years. We're going to hear a lot about good biomedicine, but also good biosocial medicine. This is a lot of good news, actually, we're going to hear tonight. And what we hear in the press most of the time, actually, is a system, an NHS, that's massively under pressure. 7.2 million on the waiting list. But there's a lot of fantastically good stuff going on in primary care, and you'll hear some. And you will hear about some of that tonight. We've got 6 speakers altogether, and we're going to go straight through the 6 speakers and then have question and answers, and then there's dinner after that. We're going to hear about important and constructive measures that are happening in NHS England from Professor Tony Avery, who's also a GP, and then Henrietta Hughes, newly appointed National Clinical Director for Prescribing.
No, that was Tony.
Oh, sorry.
That's the Patient Safety Commissioner.
Patient Safety Commissioner. See, I'm following Sarah's words, but not very well. Yeah, so do grab hold of Henrietta. She's new. I heard her speak at 11 Downing Street in front of Jeremy Hunt. She was absolutely to the point and said it as it was, and was greatly respected in the room for doing so. We then got James Humphrey, who conducted patient focus groups for government's National Overprescribing review, will report on what those patients said they really want from consultations with doctors and health professionals. And I think that's going to be really interesting. I've spoken to James already, and I think he's going to tell us quite a lot of interesting things, actually, about what patients really want, not what people think that patients want. And as the National Overprescribing Review highlighted, rather than a pill for every ill, many patients needed what was called social prescription, a term that we invented 32 years ago, as I said to Tony earlier on, because it was a secret conspiracy to re-educate all the doctors and nurses in this country using their language. But don't tell them that. This will look at the factors in their lives that are influencing their health and support them in all sorts of different ways, as Brighton GP, Dr. Laura Marshall-Andrews, and social prescribing team leader Gay Palmer and Kevin Fiala. Have I got that right? So what you're going to hear about is a great mix. Is what I would call actually what's going on the ground, but also the 80% that Professor Marmot would say is missing from the traditional approach in medicine. The traditional approach of what I was taught as a doctor, which was the biomedicine, which can deliver great cures and great medicine, but can never be the whole story for patients, because if you just focus on what is the matter with them and not what matters to them, we're never going to be, I think, a really effective doctor. And so social prescribing, we would say, is something like 80%. Of course, what social prescribing also does is challenge some of the biomedical models that we know and do have a look at Beyond Pills, led and written by Sarah, a fantastic piece of work, actually. Look at the hashtags there, so if you want to tweet, please do. And highlights, I think, actually, if you look at over 65s, something up to 20% of admissions of over 65s are adverse drug effects. There's a big question about the evidence base of some of what we're doing in terms of prescribing and in the procedures in hospital. So we need great biomedicine, but we need holistic care, and we need a system that creatively challenges both to make sure that each patient gets the best and gets what matters to them, and not just the focus on what the matter is with them. And then also do please look at the College of Medicine. Sarah's part of the College of Medicine. That's College of Medicine has been key to Beyond Pills, as has the Guild, so look at their website. Have a word with Jatinder Dua. Where is she? If you want any help or assistance, they've got lots of resources for you. But finally, before I hand over to Professor Tony Avery, the Guild would like to thank our very generous sponsors, Big Health, whose CBT app Sleepier and Daylight, developed by Professor Colin Espy, is that right? Yes. Over a period of years, have a wealth of evidence and are recommended by NICE. Heather Cook and Will Goddard from Big Health are here, over there. Do have a chat with them. And they'll be glad to explain more about these safe, proven, non-drug therapies for sleep problems and anxiety. So we're going straight over to our 6 speakers. Tony, would you like to come up? And we'll go straight through the 6 speakers. So start thinking about the questions you want to ask them, and I'll try and get as many questions in as possible.
Great, thank you. Can I just get my... So, delighted to be speaking to you this evening. Really, really pleased to be here. And so I'm going to be talking about a range of things that we're doing within NHS England to improve patient care by tackling overprescribing. So I will tell you a bit about overprescribing and what we mean by that, and what problems are associated with it. And then I'll talk through some of the range of approaches we're taking, really trying to take it from the sort of questions that patient or more health professional might ask in relation to the issue. Happy for you to contact me. I've been told by my NHS England colleagues that they're happy for you to use anything that's on the slide, anything that I say in the talk and the Q&A. And very happy to be contacted afterwards. But if you could do that, then there's the NHS England's email address at the bottom for our medicines team. Because if you contact me, I'll only have to say that you have to go through the comms team. But I'm really, really keen to engage and talk with people if you do want to talk with me and you want to hear more. So before I start, I did want to say that medicines do a lot of good, and we come from that perspective, and the National Overprescribing Review comes from that perspective. And I've been a GP for over 30 years now, and so I've seen the tremendous benefits that medicines can bring. We've got a fantastic range of medicines to help with almost all the conditions that patients come to us with. And if we take something like cardiovascular disease and prevention of that, then as a GP and as a general practice, we really can save lives by picking up people with risk factors early and treating them, obviously advising on lifestyle as well. But in terms of the medical treatments, in terms of treating blood pressure, treating high cholesterol, we really can make a difference with that. And then also if people develop problems, like for example people who have heart attacks, then the medicines that we can give them can give them many years of quality life. So it's not uncommon for me to be looking at the medicines of a patient in their mid-80s, for example, and look back and think, gosh, they had a heart attack when they're in their 60s, and they're still going and actually having really good quality life 25 years later. So that's just one example. There's lots of examples I could give. We've got another couple here. Genomic medicine, the use of people's genes. So we know that some medicines work better depending on your genetic profile. Some people are more likely to have side effects of medicines if they've got a particular genetic profile. So that's really making a difference in certain aspects of the NHS. But over the coming years, we'll see that increasingly coming into general practice and making use of that. And then a good news story, elimination of hepatitis C. So the NHS is on track to eliminate hepatitis C by 2025 by a really considerable investment in effective medicines, and to be sort of 5 years ahead of where international targets on elimination of that. So that's going to be resulting in lives saved, reduced costs overall for the NHS, because we're not going to have people with these severe liver problems and needing transplants, etc., etc. So that's where I wanted to start off by just sort of saying, medicines do a lot of good. But of course, sometimes medicines do more harm than good. And overprescribing is one area where that may be the case. So our definition is the use of a medicine where there's a better non-medicine alternative, or the use is inappropriate for that person's circumstances and wishes. And it may be, for example, that when people are in their younger years or middle-aged years or early older years, we might want to be really tightly controlling their blood pressure or their diabetes to try and make sure that we give them the maximum number of quality life years. But as you get older, particularly if you've got frailty, then you're more vulnerable to those medicines. So it's really quite common for me. I've had 3 examples in the last couple of months of older people in their 80s where colleagues have been trying to control their blood pressure too tightly, and they're suffering from dizziness, from falls, and it's here we need to be stepping back a little bit. So one thing just to point out is what's been happening in terms of medicines over time, and this graph here at the bottom shows that over a 20-year period from 1996 to 2016, was a doubling of the number of medicines prescribed or dispensed for patients per head in the NHS in England. Now, that doesn't mean all that is overprescribing. A lot of it is because we are doing better, that we've got more indications of more that we can be doing for patients. We've got a growing elderly population. But some of it will be overprescribing, and that overprescribing can increase the risk of harm for patients, particularly people on multiple medicines. People can struggle to take their medicines, increased risk of hospital admissions, and also there's waste. Back in 2010 it was estimated that there was over 300 million pounds of NHS prescribed medicines simply wasted each year, and we're almost certain that the figure is going to be higher now. So if to make best use of both the drug budget within the NHS, but also the overall NHS budget, this is something that we need to be tackling. Oops. So the government was aware of the issues of overprescribing, and it commissioned the National Overprescribing Review, which reported in September 2021. And it contained 20 different recommendations to tackle overprescribing. And the reason why I'm standing in front of you today is one of those recommendations was about leadership, and it was decided that there should be created the role of National Clinical Director for Prescribing. And the specific task I have is providing leadership for implementing the findings of the National Overprescribing Review. But very much as I said earlier, it starts from the point of recognising the good that medicines do, but also recognising that we've possibly gone a little bit too far in some areas, and we need to be dialing back from the sort of predominantly biomedical approach to a more biopsychosocial approach to things. So here's some of the things that we're doing to implement this program. It's a 3-year program, started last April, and our overall aim is to produce long-term sustainable reductions to overprescribing via delivery of both systemic and cultural improvements within the NHS. We've boiled those 20 different recommendations down into 7 different objectives, which we're taking forward with other agencies as well. And NHS England is investing a lot in this and wider things in terms of improving prescribing, particularly in primary care. So there's been a massive expansion in pharmacists in general practice. So there's now over 5,800 pharmacists in general practice. And part of their role is to help tackle overprescribing. An example here is we've invested £48 million in the last year to help general practices focus on quality improvement activities around prescribed medicines that may cause dependence, so things like opioids and sleeping tablets. There's been investment, particularly with the pharmacist, in structured medication reviews, and particularly trying to target those to people who are most likely to benefit from them. And then great work going on with the NHS Medicine Safety Programme, where we've got a whole range of initiatives that are helping to improve the safety of prescribing, particularly in primary care. So what I want to do now is just to give a few more examples of things that we're doing, but coming at it from that perspective of the sort of questions a patient might ask. Do I need to start a new prescription medicine? Do I need to be taking all these tablets? Do my medicines need to be reviewed? Do some of my medicines need to be stopped or reduced? So in terms of the initiating of a medicine, then it's almost certainly the case that in terms of trying to prevent overprescribing, the most important thing we can do as clinicians is think very, very, very carefully before starting a medicine in the first place. And if there is an alternative, then to be considering trying that. So promoting self-care, increased physical activity, improved diet. If I have someone come to me with, say, mild high raised blood pressure, or they're on the borderline of developing diabetes, if they're overweight, it's much, much better for them and for the system if they could lose weight, if they could increase their activity, because actually they can reverse the position that they're in. They can abolish the hypertension, at least for some years. They can reverse that position of being at risk of diabetes. So that's one thing. The other thing is that the investment the NHS has put into talking therapies, from my view as a GP, and of course it could be more, has been transformational. You know, it's no longer the case that, or it's the case now that there's a genuine choice. So if someone comes to you really distressed with depression, certainly 10 years ago, you sometimes didn't want to necessarily prescribe, but you felt, I can't be leaving this person for 12 weeks while they wait for a counselling appointment. Whereas now it's a genuine choice, certainly in our area in Nottinghamshire, you know, people can be seen within a couple of weeks. And so that's really, really, really helpful. And then of course the thing that we'll be talking much more about tonight, and so I won't talk about it too much myself, is the fantastic investment there's been in social prescribing link workers, care coordinators and health and wellbeing coaches, which in some cases could be a really helpful alternative to medicines. There's been some conversations about medicine. So this picture, I was speaking to Keith Ridge, the previous Chief Pharmaceutical Officer, yesterday, and he told me that this picture came from a family that had actually sent in, this is just a sample of the medicines that a patient was taking. They've gone around, the person had unfortunately died, they've gone around to the house and found stashes of medicines that have been unopened. And it's really to make the point that this is just crazy that there should be this waste going on. And you know, we've heard from patients they want better conversations about their medicines, including being able to be honest about when they're struggling in terms of taking their medicines, so that we can avoid situations like this in terms of avoidable waste. And one of the ways in which the NHS is doing that is by delivering personalised care and trying to make sure that people have more choice and control over the way their care is planned and delivered based on what matters to them. And in terms of the other couple of bullets, I'll mention that in the next couple of slides. But one of the initiatives for this is the so-called Me and My Medicines charter. This comes from a patient, developed by a patient. But it's really to try and encourage those better conversations and recognising that while we may have some expertise as healthcare professionals in terms of medicines, that people are the experts in their own selves and their own conditions and what matters most to those. And we shouldn't really sort of say it's okay to ask, but it is important for us to be promoting that, to say it really is okay to ask. We want you to be asking about your medicines so that people can get the best from their medicines and also identify when actually they may not be the best thing for them. Now in terms of medicines review, it's very important if you start a medicine that actually you review that pretty soon afterwards, just to see if it's working, certainly if it's one that might be used long term. See if it's working, if it's causing side effects, if it's really producing the sort of level of benefit that a patient really feels justifies taking that extra medicine. But also for people on long-term medicines, it's really important to have reviews periodically. And something we're particularly focusing on what we call structured medication reviews. And these are reviews usually carried out by pharmacists that provide more time to a discussion with patients. So definitely the patient or the carer to be there, where you have the chance to go through each of the medicines, make sure that the patient understands why they're taking them. You have a conversation about whether they feel they're helping, whether they're getting any side effects, And this gives an opportunity for that shared decision making around whether to continue medicines or whether perhaps to discontinue them. So as I say, overall we're already making considerable investment in structured medication reviews, and we're taking advantage of the fantastic data the NHS has in order to try and make sure that we can target those to patients who may benefit most from them. Here's a particular, quite extreme example of what happened from a structured medication review involving a pharmacist, and it was tweeted by one of our colleagues that got about 250,000 impressions, so it clearly sort of hit the mark. But this was following a structured medication review. A patient was actually not taking their medicines because they're concerned about side effects. Managed to agree with the pharmacist that actually perhaps we'll just go for the two essential ones here. And so those bowls are the before and after there, so quite a dramatic difference. So non-stopping or reducing medicines. So taking some medicines for longer than necessary can do more harm than good, particularly with those examples that I think I've given earlier. And it's certainly the case that prescribing is much, much easier than stopping a medicine. So, you know, while some examples you feel, well, we ought to be able to do that fairly easily, it is quite a challenge. You know, people have been on these medicines for many, many years, so that often I will look at a person's medicines and think, actually, we can stop nearly all of those. But then you have the conversation, and people don't necessarily want to stop because they're quite wedded to them, and they may have been told that, oh, you've got to take the aspirin, you've got to take this, and you've got to take that. So it's not straightforward. And so one of the things that we're doing is to try and make sure that GPs in particular and pharmacists in primary care develop the sort of skills and particularly the confidence. So through the Academic Health Science Network, we're developing these sort of workshops or action learning sets to bring GPs and pharmacists together, sometimes with experts like geriatricians, to really help them with this. And then I'm also really excited that from spring this year, we're going to be publishing a framework for action for integrated care boards and primary care teams, focused on trying to tackle and help with strategies for dependence-forming medicines and medicines associated with withdrawal symptoms, so that where people do want to come off these medicines, we've got more help for that. So that covers benzodiazepines and Z-drugs, which are commonly used for sleep problems, gabapentinoids, which are pain relievers, opioids for non-cancer pain, and antidepressants. So the framework will contain 5 actions and related resources that can be adapted and used by systems to develop their own plans. And in particular, the thing I'm keen to emphasise is for those ICDs to be thinking about the commissioning of services to try and help with that. So here's one particular example. We've got lots of amazing examples from around the country, but here's one from Great Yarmouth and Waveney. They found themselves on the wrong end of the spectrum in terms of overprescribing of opioids. And they took a sort of system-wide, multifaceted approach to that, and over a 3-year period were able to reduce by 35% the spend on opioids. And this initiative is now being rolled out across that whole region. So just in summary, while medicines can do a lot of good, they can also be harmful, particularly when overprescribed. And within NHS England, we're promoting a range of approaches to address overprescribing, including better guidance for healthcare professionals, funding alternatives to medicines where these are appropriate, funding pharmacists to do structured medication review, and encouraging better conversation